I'm Dr. Izanne Roos. I'm a neurologist at the Royal Melbourne Hospital Neuroimmunology Centre and a senior research fellow at the University of Melbourne. So, multiple sclerosis is a condition that affects about 2.8 million people worldwide and approximately 33,000 people in Australia. Multiple sclerosis is often mentioned as the most common cause of non-traumatic disability in young adults. And because of this reason, it typically affects people when they are young and contributing to the workforce and when they're in their kind of reproductive years. And for that reason, has a significant impact in their lives, and not just their lives, but the lives of their families and their loved ones. It is a complex condition that is associated with quite a interesting combination of inflammation and subsequent neurodegeneration. And clinically, what we see when this happens is that people get exacerbations called relapses from which they may or may not recover completely. But alongside that, there might also be this slow progression or accumulation of disability. And over time, we've come to learn that there is really quite an important interplay between these two processes that together contribute quite significantly to the disability people with MS experience. That follows on quite nicely from what we just discussed in terms of MS being a condition that has these episodes of worsening called relapses, but also the slow disability worsening. And people with MS accumulate this disability in quite different ways. Now, for many years, this has been referred to as different MS types or MS phenotypes, where some people have an MS type that is much more characterized by these relapses, and that's often called relapsing remitting MS. But for other people, either over time or even from the start of their journey with multiple sclerosis, they might just get the slow accumulation of disability, which is sometimes referred to as primary progressive MS. Now, this is important because our treatments work predominantly on that inflammatory relapsing phenotype. And we have fantastic treatments that stop relapses. But for people who have a type of MS that's more characterized by the slow disability worsening, our treatments are not quite as effective. And we've seen that in the results of the clinical trials. Now, the types of treatments where there has been some success in reducing the predominant slow disability worsening is a group of treatments called anti-CD20 therapies. And I'm going to refer to them as a group just because they probably have very similar mechanisms of action. Now, in the trials, the anti-CD20 therapies have resulted in a modest improvement in people who have not so much relapses, but more disability worsening independent of relapses. However, it hasn't been as marked an improvement as what we see in people with predominant relapses. Now, this is important because when people started treatment, both the person with MS and their family, as well as the clinician looking after them, we need to have a reasonable expectation of what the treatment response is going to be, because people need to plan their lives. But also, we know that no treatment is without potential risks. And these anti-CD20 therapies do suppress the immune system. So when we start a treatment, we need to always make sure that there's a reasonable risk-benefit balance. So we need to have a reasonable idea of how effective these treatments are at reducing disability. And that's really where the aim of this project comes in that we want to use real-world data. And in MS, we are quite fortunate in that we have access to big registries where people with MS have very kindly donated and continue to contribute clinical data to their registries to kind of recreate a clinical trial in the real world by using this data and seeing whether or not there is an impact on disability worsening when people with more progressive forms of MS are treated with anti-CD20 therapies. Firstly, it will give people a realistic expectation of the treatment response after starting these therapies. And that's, of course, important. It will help both people with MS as well as their clinicians to have an open and realistic conversation about what the impact will be of starting these therapies. And therefore, there'll be able to be a realistic conversation about the risk-benefit balance. Because the last thing we want is to put people at unnecessary risk of harm by being treated with these therapies. And also, people need to have a realistic expectation of what their journey with MS is going to look like once treated with these types of therapies. This is very important, not just from an individual one-on-one basis when talking to somebody with MS, but also from a access to therapy perspective. Now, in Australia, we are very fortunate, particularly in people who have that more relapsing phenotype with MS, in that we have lots of treatments available. In fact, our access to treatments for relapsing MS is unparalleled very much compared to anywhere else in the world. However, for the more progressive forms of MS, we do still have restrictions in the types of treatments that can be prescribed. And if we are able to show with this research that treating people with progressive MS with anti-CD20 therapies has significant benefit on their long-term disability, then that can result in regulatory changes and changes in access to therapies on the PBS, which will have significant impact and hopefully benefit for people with MS and their long-term disease course.